New federal rules require some Medicaid recipients to prove they qualify for a medical frailty exemption or lose their health coverage. Here's what you need to know before it's too late. In this episode of Care Talk, Nicole Jorwic at Caring Across Generations breaks down the new Medicaid paperwork requirements that take effect next year and the proposed new rules that determine who qualifies as medically frail. Welcome to Care Talk Live, a weekly American healthcare policy show and podcast where we explain how healthcare works or doesn't work and get you answers. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Be sure to subscribe to my channel or podcast wherever you get your podcasts to get future Care Talk shows. What do the new Medicaid work requirements actually demand? Who qualifies for the medical frailty exemption, and how hard is it going to be for people to prove that they need it? How does the new CMS interim final rule reshape eligibility for people with serious illness and disability to be able to keep their health care? Welcome to Nicole Jorwic, the Chief Program Officer at Caring Across Generations.
Thanks.
Welcome.
It's nice to be here.
So let's start with why we're even talking about this rule change, which is due to the big, ugly bill that passed last year that dramatically cuts Medicaid.
Yeah, the administration already enacted these historic cuts to Medicaid through H.R. 1. And this is a program that allows people with disabilities to live independently in their homes and communities. But now the mechanism of those cuts of almost half of the over $900 billion that's being cut, the mechanism of those is work requirements, or as you so aptly said, paperwork. And it really puts the independence and hard-won fought and won rights for people with disabilities at risk, because the way that the administration is interpreting the work requirements is by actually going further than what Congress intended. And so these cuts that already are going to be, just because they exist, impact so many people. Now the way that they're making the cuts are going to be even more harmful to a lot of people and even more complicated for family caregivers and care workers that are helping people navigate the system and people themselves navigating the system to actually get through.
So these cuts that are being executed, this red tape, these paperwork requirements, every American on Medicaid is going to have to jump through these hoops next year to keep their health care, right?
Well, the work requirements and some of it depends on whether or not you're in a state that has expanded Medicaid, but 40 states have expanded Medicaid. So the vast majority of the 80 million people who are covered by Medicaid are going to have to jump through these massive paperwork holes in order to keep and maintain their eligibility. And they're making it even more complicated, again, by the way that they're interpreting the law. And so all of us, so I have a brother that's receiving that uses Medicaid for home and community-based services. Anybody who is covered by Medicaid, whether it's for your health insurance or other supports like long-term care, you need to be vigilant about watching out for the way that your state is enforcing the rules that the federal government is putting down to implement those cuts.
So let's talk about specifically these medical frailty rules, which is many of the people on Medicaid have chronic conditions or serious medical conditions, and Medicaid is their lifeline. So now what are they going to be forced to do to keep that health care?
Yeah, I mean, it's really a really cruel catch-22 for people with disabilities, because many people with disabilities live with conditions that are real, serious, and can limit their ability to work, but they're not going to necessarily show up in a database, because the way that the federal government is interpreting this is that states are going to have to be really clear and specific about the types of people that they're covering. But for medical frailty, they're going a step further in that they're connecting coverage, the ability to work, to medical frailty. So if you're going to to take the medical frailty exemption. You're a disabled person and you're going to say, I'm going to be exempt from these work requirements because of medical frailty, then that means you have to say that you also cannot work. Now, that's, first of all, just inaccurate. So the work requirements include either work or some other community activity like volunteering for at least 80 hours a month. However, many people with disabilities, they may be self-employed and only working 10 hours a week. And so we're asking them to give that up, to give up their independence, their financial well-being in order to maintain their coverage, which is, again, complete overstep and beyond what was contemplated in HR 1 last year. So the medical frailty, the way that they're narrowing it and the way that they're connecting it with the ability to work is really, really problematic and also really indicative of how the administration views disabled people.
And it seems to me like it's not obvious how you prove that you're medically frail either. When I was diagnosed with cancer, my doctor told me face to face, but it wasn't like I got a letter in the mail saying, you have cancer and you're unable to work now. And I could then, I could mail that in to the Medicaid office. If you have a chronic condition your whole life, especially if it's hard for you to access the medical system as it is now, jumping through all of this red tape is going to be especially hard for people with serious medical conditions to be dealing with those conditions and now dealing with this system that's trying to take away their health insurance.
Yeah, it's dealing with the systems that are already complex to navigate. And then you're going to have to be reproving, whether it's through eligibility redeterminations every 6 months, work requirements at least every year, but also to your point about building the record, building the case, whether you're a family caregiver or a disabled person, the administration's interpretation of the rule also very much narrows the idea of self-attestation. So you can't, right now, they're going to leave it open for the first year for self-attestation to work as a way to qualify in most cases for medical frailty or family caregiver. But those narrow really quickly, and they're allowing room for some states. They don't have to allow for it for that year. So states could also narrow the ability to self-attest versus getting a doctor or somebody else to help you build that case, build that record. And so it's problematic all around. And again, it's just a really flipped and twisted way to think about the support that you need to have to constantly prove that you continue to need that support, especially if you're someone with a disability or a chronic illness that isn't going to go away, that was there yesterday and is going to be there 6 months from now. It's incredibly demoralizing and just not something that was contemplated in the policy.
Mm-hmm. And also for people that have not had experience applying for and getting a disability help, it is not an easy process. And there are many millions of Americans that are disabled that do not qualify as disabled because the system is not easy to navigate to, like you said, to be able to see the exact doctors, get the exact forms done in the exact right way, and jump through all of these hoops to attest what you know is true. And this is just going to force more people to go through this. Can you talk about how we know this means that people who need their health care are going to lose it based on what we saw in Arkansas?
Yeah, definitely. So Arkansas showed Arkansas did work requirements once. They got knocked down by the court, but they have to do them again. Now under the federal law. And what became really clear is that work requirements actually don't incentivize work. There was no showing in Arkansas that people who were forced to work, that it improved those outcomes. And so what it actually did, though, is stripped tens of thousands of people of coverage. And we know from analysis by Urban Institute and Manat Health that at least 5 million people will lose coverage just it getting lost in the red tape. So it's not, we don't have to, so those are the projections, the 5 million, but then we again have the data points of both Arkansas and Georgia where massive tens of millions of dollars were spent on building. Because that's the other perverse thing about all of this, is that you're cutting federal Medicaid investments by almost $1 trillion. And then you're also creating all these red tape. That red tape costs money for states to create, because it costs states have to then create the systems. So that's what you saw coming out of Georgia too, is tens of millions of dollars going to a consulting firm to build the systems that ultimately meant that less people were covered. So it's states having to spend money to kick people out of coverage. And again, the people that have to actually deal with the red tape being left without support. And you're talking about 50 different programs because Medicaid is implemented differently in every state.
Mm-hmm. And as you mentioned earlier, people that are able to physically work part of the time are going to have to choose whether they keep their work or whether they keep their insurance. It's forcing people who cannot meet the strict requirements of how much you need to work to choose.
Yeah, it really creates a catch-22 for disabled people. Either work the little bit that you can to help make ends meet and lose your Medicaid because it's not enough to meet those 80 hours, or stop working to prove that you qualify for the exemption and lose your income. And as a disability rights advocate my whole life, disability advocates, states, and employers have worked really hard to expand access to community-based employment. So this policy just flies in the face of all of that work.
So given we know what's coming, this is not final yet, right? So what should people be doing?
Yes, I'm really glad you asked that, because this is just a proposed rule at this point. So the rule is open for public comment until July 31st. So folks should push back, should make sure that these particularly egregious pieces are pushed back, and also really, frankly, just encourage folks, especially in the Senate, in the Congress, to also give room for states to have more time. All of this is happening in a really rushed capacity. So one, comment on the rule. You can join Caring Across Generations, along with a lot of our disability partners, are planning a town hall on the Medicaid work requirements on July 14th. So you can join us there to learn more about how to submit your own comments, because we do have that time. And also we should be pushing back, obviously, against the Medicaid cuts as a whole, but in particular for work requirements that as of right now, states have to implement by January. There's no reason that we shouldn't be asking Congress to give states more time, especially as this confusing and more narrow view has come out of the administration. We can push on all sides, both administratively and also in Congress.
Thanks. And where can people find out more about the work that Caring Across Generations is doing to fight this rule?
Yes, definitely. So folks can find all of our work at caringacross.org. And if you follow us on at caringacrossgen, that's GEN, on any of the social media channels, you'll definitely see the ads, or caringacross.org/join us. And you can get on our list where we'll be sending out things around the Medicaid town hall and all of the work that we're doing on the work requirements, and also making sure that we lift up the needs to reverse these historic and awful cuts.
Thank you again for joining us.
Thanks so much, Laura. Appreciate it.
And just a reminder that we have free or low-cost healthcare resources available on our website at healthcarevoices.org/care talk. So check it out. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. And now our experts will answer your health insurance questions. So welcome to Louise Norris, Health Insurance and Healthcare Reform Analyst at healthinsurance.org, and Diane Archer, the founder and president of Just Care USA. So let's start with Diane. Tell us more about the Trump administration's latest healthcare regulation on insurers and loans.
Yeah, so just as the situation is dire for people with Medicaid, and as we've discussed on the show, for people in the Affordable Care Act state health exchange plans, The situation is not getting any better for the people in those state health insurance exchange plans. The Trump administration's latest final rule that is not going to be challenged is one that has to do with high deductible health plans, super high deductible health plans in the state health exchanges. Fortunately, at the moment, not too many people are in them. But with health insurance prices going up and up and up, you have to assume that if people decide they're going to keep health insurance, they're going to be forced into these high deductible plans. And the problem with these high deductible plans, as we all know, is that most people end up skipping care because they can't afford what is now going to be a $10,600 deductible. So the Trump administration solution to this: let the insurers give people loans to help cover their deductibles. That solution is one that allows the insurers to offer these high deductible plans, but it's also one that is just intended to lead more people into medical debt. We have 100 million Americans with medical debt today. Anyone who ends up borrowing money from an insurer, if they're in one of these plans and the insurers are loaning them money, is only going to be in more debt, likely with very high interest rates. That doesn't help make healthcare affordable. What the Trump administration should be doing is what President Trump said he would be doing, which is lowering prescription drug costs, which hasn't happened, and lowering hospital rates and lowering doctor rates and lowering the prices for medical equipment and making our healthcare system more affordable through lower prices. But that's just not happening. Although we are, I would add, starting to see that happening in a bunch of states. And most recently, Indiana, a Republican governor in Indiana, pushed through a law to regulate hospital prices in the state, something that is usually a Democratic law, but Republican Governor Mike Braun said hospitals are in need of regulation, and we're going to limit what they can charge employers for a bunch of their services so that healthcare costs are not out of control for employers. So we're beginning to see the states, Vermont also has a regulation, Washington and Oregon has a regulation. They're limited, but we're starting to see states move, and even Republican states move to regulate healthcare prices. So that's a good opening towards potentially controlling costs. And we can only hope that the Trump administration would do the same. It's not looking likely at the moment.
Thanks, Diane. And as you mentioned, this is the insurer loans is just for catastrophic plans on the exchange. So this is a small piece of the insurance market, but the future is unknown. They could always expand it. And like you said, the focus is in the wrong place. It's not on making healthcare more affordable in the first place.
Exactly.
So we have a comment from Emily from Facebook who mentioned that they're suing their school district for forcing retirees from original Medicare and a district subsidized supplemental plan onto Medicare Advantage. Doctors are leaving their network because Medicare Advantage is doing pre-authorizations again and again. So Emily was able to go back onto the previous plan, original Medicare, but not until October. And so their school district is forcing people to take Medicare Advantage because it probably saves the district money at the expense of patients. So Diane, want to talk about that?
It's happening across the country. Employers, unions, municipalities are steering their retirees into Medicare Advantage plans just as a way to save themselves money without looking at the consequences for the people in these Medicare Advantage plans. And as I've discussed over and over, unfortunately, when you're in a Medicare Advantage plan, you're gambling with your health because there is widespread and persistent delays and denials of care that is happening in Medicare Advantage and is pretty well documented now. We don't know which plans are the worst actors, so we don't know how to steer people away from the bad actor plans. We have to assume that any plan you end up being in could be one of those plans. And that means that it's going to be harder to go and see the doctors you want to see, use the hospitals you want to use. It's going to be harder to get the care your treating physician believes you need, because Medicare Advantage insurers tend to second guess treating physicians and deny care, often inappropriately. It's only traditional Medicare that covers care from most doctors and hospitals across the country and doesn't second guess the treating physician. So if you can, it's always best to be in traditional Medicare if you want to ensure you're going to get coverage for the care you need when you need it.
Thanks, Diane. And then a question from Saul Invictus on Reddit, who says that my wife's employer provided health insurance is with United Healthcare. She is afraid to have an autoimmune blood panel done privately because she thinks that United Healthcare can then use that action to deny other uses of her insurance with them for other issues. So this goes back to pre-existing conditions in your health record. Louise, can you talk about that?
Yes, absolutely. So in this case, I can put your mind at ease that your wife can get the blood, whatever panel she wants. Same thing with like genetic testing, any sort of testing you want to get. You no longer have to worry about your medical history being a factor in your coverage going forward. This is a direct result of the Affordable Care Act. This was a really big problem in the individual market for plans that people bought on their own prior to 2014. Insurance companies could comb through your medical records. They could charge you a higher premium based on your medical history. They could exclude certain services, certain parts of your body. It was definitely a problem. But the way the Affordable Care Act changed it is it does not matter, and this is true for employer-sponsored group plans as well as individual market plans. It does not matter what your medical history is. Insurers cannot exclude pre-existing conditions. They can't charge you a higher premium based on you having a pre-existing condition. Premiums can only vary based on your age and where you live, and whether or not you use tobacco. That's in the individual and small group market, but there's not this concern anymore that you need to worry about your medical history being an impediment. There are some exceptions because there are some plans that are not regulated by the ACA, and people sometimes fall victim to not realizing that those plans are different. So that would be things like short-term health insurance, Farm Bureau plans, healthcare sharing ministry plans, fixed indemnity plans. Those plans do still use medical underwriting and can do all those things I was just mentioning. But as long as you have a real individual market plan or a group plan offered by an employer, go ahead and get whatever testing you need done. It will not affect your coverage going forward.
Thank you, Louise. And then we have another comment from Susan via Facebook, who says that I had cataract surgery on one eye approximately 10 weeks ago. I have Medicare and Humana Medicare Advantage. Medicare would normally pay the entire bill, but Susan got a call from the provider saying that she owes more money. Several calls later, she learned that Humana was primary and Medicare was never billed. If Medicare had been billed, I would have owed $0, and Susan still has the other eye to get fixed. So Diane, can you give us some thoughts for her?
Yes. Unfortunately, Susan is in a bind where she is going to end up having to pay the full cost of her eye surgery. As a general proposition, when Medicare covers a service, the supplemental plan, the BCBS plan in this case, picks up the 20% coinsurance. But there are a small number of doctors across the country that have opted out of Medicare. And that means that they will not accept Medicare payment whatsoever. And if that is the case, they must make you sign a waiver agreeing to pay privately for the service. Once you sign that waiver, Medicare and your Medicare supplemental insurer will not pay for the service. And that means that you are fully liable. In no situation will your Medicare supplemental coverage pick up the coinsurance if Medicare hasn't paid as the primary payer for the service. So in this case, the Humana Medicare Advantage plan is the primary. It's not paying because the doctor's opted out of Medicare. And that means that Susan is going to have to pay the full cost. I'm not sure exactly why. I'm assuming in this case that Susan is out of network. If she's in a Humana Medicare Advantage plan, I should have said that. And then again, there's no basis for the Humana Medicare Advantage plan to be paying.
So what should Susan do before she gets the other eye done?
I would advise Susan to go to an in-network Humana Medicare Advantage surgeon, and then she will be liable for the copay in most cases. But if she has a plan that wraps around Medicare Advantage, then it would pick up whatever it was Medicare Advantage didn't cover. It's a rare situation in which there's a plan that wraps around Medicare Advantage, but there are some.
Thank you, Diane, and good luck to Susan on the next surgery. And thank you, everybody, for joining us to learn more about healthcare policy, patient rights, the fight for a just healthcare system, and answers to your questions on health insurance and healthcare. Be sure to check out more free or low-cost healthcare resources on our website at healthcarevoices.org/caretalk. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more. Be sure to subscribe to my channel or podcast wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.